that he derives from that happen to be really good friends of mine in the cattle business. And so that friendship has grown since then, and we've been able to work together too, especially at the Southern Surgical Association. In looking over just some brief things about David, one of the things I would tell you is I remember in the 1970s as a resident going to the College of Surgeons meeting and some different meetings like the American Burn Association and so forth, a call out at that point that we needed more surgeons to be involved in basic research. And David Herndon probably fits that bill. He came along about that time as a medical student and resident, worked in the Army and then on to his career in burn surgery, but he fits that bill probably better than anybody that I know of. And that's one of the reasons that I wanted to have him come here and let our residents and medical students in particular have a chance to see somebody that put clinical medicine to work in a research field in a really distinguished way. So much so that this last fall he was inducted into the National Academy of Medicine, which parallels the National Academy of Science, and is really the penultimate award for anybody who does research work or who is involved in healthcare delivery. I know one of the things in studying about Alfred Blaylock and his life many years ago, of all the awards and things he did, the thing that he treasured most was being in either the National Academy of Medicine or the National Academy of Science. So that's a huge compliment to David. He's won every research award that I know, including the Flance Carl Award, which the American Surgical Association awards to the outstanding achievements in research activity. So you're talking to somebody who's a true triple threat individual and also a nice guy who still sounds like he's from Texas, because he is from Texas at this time. That's where his career's been and his research work. So Dave, we look forward to hearing this. I first heard him talk about this, forgotten the named lecture it is at the college, I don't know, 5-6 years ago, about modulating the metabolic response to stress and trauma. And so we look forward to hearing this. And then tomorrow, for everyone, I'll remind you that he's going to give us an overview of the treatment of burn patients, which ought to be an excellent talk as well. Well, David, we're happy to have you here.
Thank you, sir.
All right.
It is a great honor to be in.
That's on. Is it on?
It's a great honor to be here.
There you go.
Thank you very much. I really came to see where the true champion cattle are grown, and for a Texan, that's pretty humbling to understand. I'm going to talk about the metabolic response to severe injury today. I'm going to use burns as a primary example because, of course, that is the area that I've done research in, and the hypermetabolic response that occurs after burns is greater than it is after other surgical and medical traumas, but they are all in common having a tachycardic response, an increase in cardiac output, and massive increase in energy expenditure that your patients in the ICUs that we'll talk about later today demonstrate. And they become cachectic and lose protein over time in ICU, with muscle wasting being much greater than we generally appreciate. And as pictured in these unfortunate photographs, the response lasts not just when in ICU, but for up to 2 years after the time of injury. This is a 60% total body surface burn at the time of admission. And at 3 months post-injury, a child with this kind of injury now routinely lives due to advances in care we'll chat about tomorrow, but hardly able to walk at 3 months post-injury. 2 or 3 therapists have to assist the child in walking, and so weakened in the arms and legs that contractures occur in the axillas and the antecubital fossa in the wrists, hands, because the patient's weakness is unable to fight the raised red scar that grows for 6 months to a year inexorably on the child, releasing cytokines and causing itch and causing pain and anxiety for a prolonged period of time. Children, in fact, don't grow for up to 2 years after the time of injury. There's no new bone growth. Muscle is continued to waste for 2 years post-injury. Now, the response is much greater in the burn child that you saw here and those that I'll give examples of as this talk goes through than it is after skeletal trauma and your patients with sepsis or infection. But the response is common to sepsis, trauma, and burns. Burns, the response is slightly longer and slightly more pronounced. It involves substrate being broken down from bone and muscle, recirculating sugar to the liver by the Cori cycle. Sugar is used by the heart, brain, and the kidney, and inflammation and growth of new wounds. It's an adaptive response, but the catecholamines, glucocorticoids, and corticosteroids that mediate the response are so massively elevated and for such a long period of time that the body erodes. Up to 10 to 20% of the total body erodes in burns of 50% of the total body, 30% in those of 70% of the body, and up to 40% in those with burns over 80% of the total body surface, almost in spite of all the therapies that we have concocted to thwart this response. So generally, we can thwart the response in intensive care units, except in patients who develop sepsis. Now, all of us define sepsis in common ways by presence of three of the physical findings depicted on this slide and bacteriologic sources for infection. In burns, that's green dots, blue dots, mainly bacterial and fungal infection in the burn wound, but also in the lung, as these patients are immune suppressed for prolonged periods of time with bacteria growing in fortuitous places on the surface of their body that invade and cause septic responses episodically throughout their care. And when a patient becomes septic, this hypermetabolic, hypercatabolic response, as depicted on this slide, comparing septic to non-septic individuals, the resting energy expenditure increases 30% in a patient once they become septic, and not just during the period that they're septic, but for up to 2 to 3 months after the period that they're septic. There's a true genetic reset that occurs in response to sepsis and burn injury and to the ravages of patients in intensive care unit that cause this response, leading to negative nitrogen balance, loss of muscle, weakness. The physiologic response, leaving these patients remarkably weak in the burn patient, delays reintegration into society and leads to a contracture that requires extensive occupational and physical therapy and plastic surgery. These are bone growth studies in 180 burn patients with burns over 40% total body surface. The pediatrician's height velocity and weight velocity charts show the patients in black dots, and they're less than the 5th percentile. They don't grow for up to 2 years after the time of injury. Bone doesn't grow, as depicted by dual image X-ray absorptometry, with almost all of the patients being less than the 5th percentile in bone mineral content and density. And if you do tetracycline labeling studies, as we did on the left side of this slide, there is no bone growth for 2 years post-injury. I had the opportunity with my partner, Jung Lee, to study 242 patients who we did not have on any anabolic agents or These are control patients, or patients who entered into studies to try to ameliorate this response, but pulled the card that did not receive drugs. The patients that we study are big burns over 50% of the body. Fortunately, due to modern treatment, their length of stay is only a half day per percent total body surface burn, and their hospitalizations are not that long, 30 days, but these responses do persist for years after the injury. These patients do have wound infections. They do have smoke inhalation injuries, and 17% of them have very massive septic episodes. Looking at this group of 242 patients and seeing what mediates this hypermetabolic response, the inflammatory cytokines, interleukin-6, interleukin-8, GCSF, and MCP1 are higher than recorded in any other disease process. These inflammatory cytokines are elevated in your patients in the ICU, and the latter, cytokine and their like, lead to immune suppression, whereas the former lead to hypermetabolic responses and acute phase responses in the liver. As I alluded to, the hypermetabolic response is mediated primarily by the fear-fright hormone catecholamine, which is tenfold elevated for up to a year post-injury. This slide depicting 60 days after injury. Corticosteroids are tenfold elevated for up to half a year post-injury, and here depicted at 60 days. Well, all of you know that catecholamines cause you to be nervous and your hands pad back and forth, and to have a fear response in the pit of your stomach. It causes tachycardia, it causes lipolysis, it causes anxiety, it causes fear. Corticosteroids delay wound healing and cause immune suppression. And these levels are as high as patients in corticosteroid storm, patients with Cushing's disease. Resting energy expenditure is elevated, 140, 150% above normal in burns. In the ICU, a patient with multi-organ failure will have an elevation of about 30% above normal. They'll be tachycardic. Their heart rates will be elevated above normal. If you do nitrogen balance studies in the ICU or do cross-leg nitrogen studies, they're losing nitrogen from their muscle. Cardiac output is elevated in these patients, 150 to 160%. Heart rate, these children can have heart rates of 180, 140% above normal. In adults, they can be 120, and not just for a little bit of time, but for months. We participated in a study with many trauma centers and centers of critical care, comparing genetic responses after trauma and sepsis and after massive burn with normals. And the red-blue column on the left is the normal population that was garnered from elective surgical patients, plastic surgery patients with cosmetic operations, and pediatric patients with hernias. The burn patients are depicted on the right at 0 to 4 days, up to 60 days post-injury, and it doesn't take a rocket science to figure out the difference. 2/3 of the genes are altered in the white blood cell population after injury and for 60 days post-injury. The genes that are altered are primarily immune genes, where the patients are tremendously immune suppressed. And it's not surprising that the non-survivors are more suppressed than the survivors. Adults are more suppressed than children. This information can be used to predict who probably will and won't die within days of the time of injury, or at least to focus more aggressive care on those with more depressed immune systems and with more revved up metabolic responses. The gene families that are downregulated are mainly adaptive immune related. T cell signaling, IL-4 signaling, CD28 signaling, antigen presenting pathways are 10 to 20-fold depressed in these patients over time. But it's not just the white blood cell population that's altered in response to trauma and sepsis and in the ICUs, it's every cell in the body. 2/3 of the genes in fat are altered. Unlike the immune system, though, fat is upregulated and turns into a really angry organ after trauma, burns, and infection. Fat becomes a secretory organ, secreting inflammatory mediators, interleukin-6, interleukin-8. 2/3 of the genes that were downregulated in normal individuals are upregulated in fat, and it contributes tremendously to the hypermetabolic response, secreting leukocyte extravasating signaling so that leukocytes come into the fat and to the granulating tissue on top of it in burns, or to the wound around a broken hip or a broken leg. GM-CSF signaling, HMGB1 signaling, initials that have been given to profound modulators of inflammation. These more obscure names are also inflammatory pathways, and acute phase protein signaling, important in the liver, may be a little bit more recognizable to you. To pull one pathway that is profoundly altered in your patients in ICU and these burn patients, that results in a typical clinical finding, hyperglycemia that requires insulin infusion in the ICU, is the insulin signaling pathway. Now, after burns and after major trauma, glucose flow is really 3 to 7-fold elevated in patients. There is an increase in entry of glucose into muscle and into fat by the GLUT pathway, which is depicted here in red. But the insulin pathway, where the genes are downregulated massively, is predominantly depicted by blue dots here. The two pathways intersect at nuclear responses where FOXO, HEMOX, atrogen, and I realize these words are foreign, but they're extremely important nuclear factors to cachexia. They lead to total body cachexia. They lead to activation of ubiquitin and breakdown of muscle. And they also lead to immune depression. It is the conspiracy of the up and down regulation of genes in the body in both muscle, fat, and the immune system that leads to this tragic response. Fat is angry. There's a massive increase in lipolysis, fat released peripherally, goes to the liver, gluts the liver. The liver becomes infiltrated with fat and enlarged over time. There's increased peripheral glucose protein breakdown and a decrease in ability to remove inflammatory mediators, decreased antioxidation. Vitamin C, vitamin E are down, and their ability to remove free radicals is decreased. Muscle erodes. It is totally downregulated over time. Though there's a great effort to increase production of filament and contraction, it's a futile substrate cycle in fat and in muscle that ends up consuming energy and losing muscle over time. There's a suppression, as I showed you, in the insulin signaling pathway, hyperglycemia, increased glucose flow, but repatterning of energy metabolism results in muscle skidding away. There's altered mitochondrial function, and fat becomes an angry organ and immutably changes from white fat that is quiescent and not an angry organ to an organ that is multinucleated infiltrated with inflammatory cells, and fat changes from white fat to brown fat, a fat that takes sugar and makes heat. And burns, teleologically, that might be to maintain a temperature response in these individuals. There's a machine on the ground here, but I think it's probably somebody's beeper they left from before. White fat changes from that of a healthy individual to a multinucleated angry organ, positive for uncoupling protein, which is allows sugar to be metabolized to heat in a very inefficient way. It consumes massive energy sources and contributes to the hypermetabolic response, but maintains body temperature. Burns and patients hurt in the ICUs are striving for temperatures that are elevated, 38.5, 39 degrees centigrade. And the way they do that is primarily through brown fat and non-temperature dependent shivering. Now, during the past decades, we have been able to recognize this response, and we've been able to do some things about it that have been positive, reducing lean body mass and decreasing length of hospital stays and rehabilitation. The studies that have been performed in burn patients include temperature control. If you maintain the environmental temperature at about 38.5 degrees, 39 degrees, really warm, hot for nurses, in the rooms, in the halls, in the operating rooms, you can decrease the hypermetabolic response. If you remove the burn wound early and cover it right away, you can decrease the hypermetabolic response and reduce sepsis and reduce mortality. There are ways to feed patients that can maintain total body weight, but overfeeding has great negative consequences that I'll allude to briefly. Anabolic agents, growth hormone, insulin, IGF-1, BP3, have been effective in this setting. Hyperinsulinemic euglycemic clamp led to too much hypoglycemia in critical care centers, but metformin and fenofibrate have a great future in the ICU. And anabolic agents that have been fairly benign and useful in the ICUs are oxandrolone, drug abused by weightlifters and athletes, but very useful in the ICU and in patients with growth arrest for other causes. And probably more useful than any other single treatment of this response is use of the beta-1, beta-2 blocking agent that we've known about since the 50s, propranolol, and combinations of propranolol with other things. This slide depicts maintaining body temperature by external heating, keeping the rooms at 32 to 34 degrees centigrade and allowing the patient's temperature to be at 38.5 to 39 degrees centigrade is adaptive. It decreases the metabolic rate by 30%. Also, treating with morphine and anti-anxiety agents and multimodal pain therapy decreases the hypermetabolic response. One can maintain total body weight in the ICUs if you know the degree of the hypermetabolic response, which can be measured with resting energy expenditure carts in ICU. You can give 1.4 times the resting energy expenditure and maintain total body weight. There are formulas that have been derived from metabolic cart determinations, 1,500 kilocalories per meter squared for maintenance and 1,500 kilocalories per meter squared burnt will maintain total body weight. And there are other weight-based formulas. We used to use milk and fat-based formulas to support people in ICU. And if you go to your ICUs today, I think you'll find that most of the formulas up there have 30 or 40% fat content. Now that turns out to not be probably the right dietary content because of the lipolysis that I talked about is obligatory. Catecholamines cause peripheral fat to accumulate in the liver, and the patient's liver can be twice normal size. 2 weeks into such trauma because of fatty infiltration, much like fatty infiltration that occurs in other disease processes. It's very detrimental, and it's detrimental to the acute phase response. You can feed people with sugar protein solutions that decrease fatty infiltration of the liver. Now, the other thing that is critical to treating this response is early identification of sepsis and treatment of sepsis. In burn patients, you feed continuously via the enteral route, and GI intolerance is a premonitor of sepsis in almost 80% of the cases. There's a decrease in mesenteric blood flow when platelets plug, releasing thromboxane, which causes mesenteric vasoconstriction, decrease in gut function, and a decrease in gut mucosal integrity that fuels bacterial translocation from the GI tract. In burns and autopsy, over half of the individuals have multiple GI erosions throughout the GI tract. Though we've learned how to treat ulcer disease with PPIs, this mesenteric vasoconstriction is still pervasive, causing ileus, Ogilvy's disease, pseudo-obstruction coli, and bacterial translocation in younger patients, frank necrotizing enterocolitis. The vasoconstrictive release of thromboxane combines with epinephrine, norepinephrine, to decrease mesenteric blood flow and lead to frank areas of necrosis. Thromboxane is 100-fold elevated in patients who are septic and in patients with burns. This can be blocked to some extent by COX inhibitors. Early recognition, at least, and understanding of ischemia reperfusion injury and its pathogenesis is part and parcel to treatment of this hypermetabolic, hypercatabolic state, and understanding the immune dysfunction that occurs. These patients are much like transplant patients with helper and suppressor cells, 50% normal active, and natural killer cells, 50% normal active. This immune suppression is made worse by total parenteral nutrition and by high-fat feeding. If you feed people high-carbohydrate protein feeds like Vivanex and leave the fat out of the feeding formula, if that's one of the take-homes of this lecture, look at what you're feeding in the ICU, you'll do better with these responses. And don't overfeed the response, because if you overfeed it, you get more fatty infiltration of the liver, more hyperglycemia, and hyperglycemia in and of itself causes graft failure and immune suppression. This slide, red is fat and blue is lean body mass in the 242 patients that we treated as controls and gave different caloric amounts to by serendipity or by mistake. If one feeds a person 1.0 times resting energy expenditure, you do as well with lean body mass as if you feed them 1.6 times resting energy expenditure. What you do is you make them fat. There's an increase in fat mass, primarily in the liver and in the mesentery. Overfeeding patients is more detrimental than underfeeding them. But knowing exactly how much you should feed them is a pretty obligatory thing. Diet alone and temperature alone and pain control alone don't control the response. Anabolic agents such as growth hormone were tried early in the 80s and remarkably did increase epithelial mitosis rates, increased the rate at which donor sites healed, increased the rate at which epithelium produced proteins like laminin and type 4 collagen, type 6 collagen, causing wounds to heal more quickly. and improved growth in patients looked at for 2 years after injury. Growth hormone also causes hyperglycemia, however, and is difficult to use in anything but pediatric patients. It improves bone mineral content, but increased mortality in ICUs in adults. Hyperglycemia in and of itself causes muscle catabolism and immune response exacerbation, the worse it is. There was a period of time that we tried to maintain sugars at 90 milligrams per deciliter in ICU by giving high doses of insulin continuously. That led to hypoglycemia, which led to mortality that was even greater than euglycemic responses. Giving insulin will also increase mitosis. It will increase lean body mass, but it increases total body fat and causes hypoglycemia. Use of agents like metformin and fenofibrate, however, can be done safely in ICU and can positively affect muscle mitochondrial activity, and I recommend it to you. I recommend at least hyperglycemia needs to be controlled in our patients in ICU around 150 milligrams per deciliter, and using the oral agents first instead of insulin drips is a much safer and better way to control this response. Anabolic agents that can be used safely include oxandrolone, which is a testosterone analog that doesn't cause hirsutism, can be given to males and females. And when given for a year post-injury to these hypercatabolic patients, bone mineral content can be improved, growth can be improved, and lean body mass can be improved, particularly if exercise is added to the regimen of the drug in doses of 0.1 milligram per kilogram twice a day. It's fairly safe. It can cause liver function abnormalities, but they're low and small and can be monitored for. It causes an increase in muscle strength, an improvement in growth, an improvement in bone mineral content in children of all ages, and in a large study in adults. The agent that has had the greatest effect in the hypermetabolic response is the beta-1, beta-2 blocking agent propranolol. And the way you give it is just to decrease pathologic tachycardia. These children have heart rates of 180. Blocking their heart rate down to 120 causes no harm, does not decrease cardiac output, does not decrease oxygen delivery. It allows the heart to fill more fully and makes more energy efficient cardiac performance, decreases cardiac metabolic rate, and decreases overall metabolic rate, and can be given safely just by titrating to a heart rate that's still elevated and responsive to cold stresses and other stresses, but much less elevated than the response causes it to be left unabated. Propranolol can improve protein synthesis and wound protein synthesis by as yet somewhat mysterious mechanisms. Catecholamine stress causes changes in the whole of the immune system and all of granulocyte and erythrocyte maturation. It does affect directly protein synthesis, and it does affect mitochondrial responses. It eventually will decrease fatty infiltration of the liver and abolish peripheral lipolysis when given in doses to decrease heart rate by 20%. It improves muscle mass and naturally decreases anxiety. One would think that it might affect acute and post-traumatic stress disorder, but large enough studies to see whether that is true have not been possible. It clearly decreases infection potential. In this study of just 192 control and 155 patients given propranolol in an intent-to-treat randomized design, ARDS and pneumonia was decreased, minor and major infections were decreased, and mortality may be decreased in kids and adults, though larger studies are required to substantiate those effects. Combinations of the beta-1, beta-2 blocking agent and the use of oxandrolone, dietary control, control of anxiety, control of pain, can tremendously improve the lot of such terribly injured individuals. And I would posit to you that considering these modulations for your patients in intensive care are important. And your patients need to be treated not just during acute care. They need to be treated for a year or two after the insults that they've undergone, because these responses persist. The scar response in burn patients raises up a raised red inflammatory scar over a year or two post-injury that can be incredibly debilitating. Therapies that are anabolic and therapies that decrease catecholamine stress can decrease scar cellularity. They can decrease the ugliness of scar over time. Exercise can decrease contractures over time. Psychological responses can be affected by use of anabolic agents and anti-anxiety agents. Patients feel better. They go back to work more quickly. They have better sense of well-being. The agents that I've talked about using are off-label, the propranolol and oxandrolone, and it's important you know that. So if you do use them, you have to use them very carefully. There are adverse effects of all of these agents, though those with oxandrolone and propranolol are quite low and safe if you titrate to heart rate and follow liver function tests. Probably the most effective treatment of the hypermetabolic, hypercatabolic response is for surgeons to know it's occurring and to work with their patients in an early rehabilitation program starting immediately after injury, getting them up out of bed as the orthopods do for people with total hips, I've found out. They get you up right after the operation and you go home a lot quicker. Exercising people in the intensive care unit the day that they're injured, whether they be on ventilator or not, is key. If you can get these patients to do 75% VO2 max on treadmills and bicycles 5 days a week, even though they're in hospital and badly hurt, even though when they go home they have scars, they feel tired, they're weak and they're tachycardic, you can thwart this response. You can improve strength and cardiopulmonary capacity immensely, as you would in a cardiac victim of tragedy. Our patients in surgical ICU are rarely considered for this kind of treatment. They should always be considered for this kind of treatment. They should receive adequate temperature control, adequate pain control, adequate exercise control, adequate anxiety control, and a rehabilitation program that begins immediately and is sustained. Even itsy-bitsy babies can be made whole more quickly by music therapy and exercise that gets them to 75% VO2 max. They actually enjoy it far greater than sitting in bed in pain and anxiety. Running through the halls can decrease the number for reconstructive operations because muscle mass thwarts scar. Stretching thwarts scar. Anabolic agents thwart scar. And these same agents improve immune responses. As I'll talk about tomorrow, there have been remarkable advances in the treatment of burns, such that massive burns now almost all live. But the haunted response of the child that I showed you in the first pictures needs to be avoided. Treatment of the hypermetabolic and hypercatabolic state, not just of burns, but of all of our patients in intensive care unit, can affect their well-being, their return to work, their sense of self, incredibly. That so few of these massive burns that I've described to you today have tremendous psychiatric. They have great outcomes. They don't have terrible outcomes. They go back to work. They lead society. They have longer relationships than their peer group. They achieve academically better than their peer group, though they've lost limbs, they've lost fingers, and have tremendous cosmetic challenges. The resilience of human beings is incredible, and that so few of these survivors have developed serious psychological and social difficulties is a testament to human resilience. But their life can be made so much better by simple observance of treatment of a disease process that many of us have ignored for a long time. A hypercatabolic, hypermetabolic response that is omnipresent in surgical trauma and greatly undertreated. If we can put the lights back on, I'd love to entertain questions and stimulate conversation or later in the day. Thank you.
We have questions yes, Dr. Stanley.
That to me was very fascinating, just to see how there was the turning on and off of different genetic expression, and how you've determined some of the medications that intuitively would think would help indeed do help. But then I was wondering, seeing these turning on and off of genetics, are we getting to the point where we can exploit that to do designer medications that will help tweak this type of response to give a maximum survival and kind of help people through these?
Absolutely. I think that's the future for the next 5 or 10 years is to be able to specifically determine what kind of drugs are going to help what kind of people in what settings. And we will have genetic chip tests that will allow us to specifically define the responses of individuals and hopefully design drugs at a less expense than the current outrageous economic affront for drug development. But that's a hope, and it's not yet materialized. It's been a hope for 5 or 10 years. It's complicated.
I thought that was a great talk. I had a question on the metabolic cart and whether or not you believe, if you're using indirect calorimetry on the people who are intubated, how accurate it is in this day and time.
Yeah, we do use metabolic carts routinely, and you've got to know how to interpret them, and you got to know when they're not telling you the right thing, because quite clearly in intubated patients, if you've got leaks in the system, you're going to get Bazooty responses, and you have to have no leak. We generally, in non-intubated patients, use a canopy, and that too has difficulties. So you have to interpret it appropriately and do it repetitively and not just take one response. But I think it's very useful. They are expensive. They need individuals to run them and individuals to interpret them. But I use it in my daily practice to great help. Just knowing respiratory quotient helps you a lot, because if you're overfeeding people, the respiratory quotient will be too high, and overfeeding is a great iatrogenic problem.
I had a question as to, I didn't see, maybe I missed it, it's a fairly intense talk, but adrenal insufficiency on some of these massively burned patients, is that something you see, or you look for that, or what would be the incidence of that kind of problem?
It clearly occurs. It occurs less frequently than we thought 20 or 30 years ago when we, and even 10 years ago, we routinely did ACTH challenges and looked for people with adrenal failure that were requiring pressors in intensive care. And by and large, that's found to be much more infrequent than we had thought that it would be. All that being said, at autopsy, there are clearly people with massive adrenal insufficiency, and if you've got somebody who's steroid, it's always worth a try when somebody is on triple pressors and fading out. But that is less frequent than we had once thought.
In patients, I remember hearing you talk about propanolol and oxy, and I have to admit I wasn't as aware that that can be beneficial in that acute process. Would it translate over to things like the toxic DTs that patients that we've seen before with pancreatitis and that sort of thing, where you had this hypermetabolic response? I mean, is this not specifically just for burns, but can be translated to other patients?
Absolutely, and any patient who's hypercatabolic and has cachexia, this thought process of temperature control, pain control, anxiety control, adequate nutrition, and anabolic support should be considered. As far as I'm concerned, since the 50s, it was standard of practice to treat pathologic tachycardia. It's just surgeons don't like to treat tachycardia because we think it's a sign of shock, and it is, quite clearly, but pathologic tachycardia from toxic levels of catecholamine should be treated by blocking down the heart rate to one that is more adaptive and cardiologically efficient. No internist would think about letting a patient's heart rate stay up at 120 or 130. That's what they get paid all these bucks for, to get the heart rate down to 80 or 60 and the like. But we in our ICUs let our patients routinely tack along at 110 to 120. And over months, that causes incredible cardiac pathology. In fact, if we follow our patients who've been in ICU and we have let them have that kind of tachycardia for a period of time, they develop cardiac fibrosis, ventricular hypertrophy, and have increased post-discharge mortality from cardiac morbidity. It's just an unrecognized pathology that we don't concentrate on. We concentrate on other stuff. But decreasing heart rate to a normal and adaptive level is simple. You just titrate it.
Other questions, comments? Well, that was a fabulous talk. I want to, before we end, though, recognize a couple of people. Dr. Lewis Carter came in, a longtime faculty member here who has an intense interest in burns contracture. I know he may want to mention that to you later in his world travels of global health. And then we have one of our own, Chris Bell, back, who is here on leave from the Army, having come back from Afghanistan a couple of days ago or so forth, and I guess we'll be going back there as he starts his career in surgery in the Army, as did Dr. Herndon started his research career in the Army as well. So parallels there. Welcome back, Chris. We're glad to have you. David, that was a fabulous talk. I think for everybody here, it would be a recognition of a lifetime dedicated to research. I'm sure you couldn't help but notice all that data. The name Herndon was present in virtually every part of that bibliography, and give you great credit for developing the careers of a lot of other people, and that you let a lot of those other people be first author on those papers, which speaks well of you. Thank you very much. We look forward to the talk tomorrow on burn therapy. Appreciate
you.
it very much. Thank you.
Thank you, sir.
Every time you get into that, you're understanding the physiology.
Thank you so much.